ഇതിപ്പം ഫുൾ സ്ക്രീൻ ആയാലും ഹാഫ് സ്ക്രീൻ ആയാലും അതിനകത്ത് വരുന്ന ഒന്നും ആയിരിക്കും. ഫുൾ സ്ക്രീൻ ഇട്ടാൽ കുഴപ്പമില്ലല്ലോ, വരില്ല. Good evening. Welcome to Senadhipan Education Foundation. This is a test trial of a PowerPoint presentation in YouTube. So if there is any problem in visualizing this or any problem in sound quality, please inform me. So I told you that I will be taking a lecture on abdominal wall reconstruction, the basics. So this is just the basics of abdominal wall reconstruction. I will not be going through the technical details. So we will be having separate sessions on technical details of how to go about each and every surgery. I'm planning to have different speakers for different procedure, like anterior component separation. One person will be talking about. Emulos, another person will be talking about. Scholar, some other person will be talking about. And few speakers are already agreed to give their perspective on this different procedures. Probably next Sunday 4 p.m. Dr. Pramod Shinde from Nasik, who is a senior surgeon in this field, will be delivering a lecture on anterior component separation. So before that, let me check whether this is working. I actually discussed with him regarding the YouTube PowerPoint presentation, but we'll check how this is working. Otherwise, we'll take some other options for presentation. So abdominal wall reconstruction is nothing but tension-free approximation of well-vascularized tissues with the reconstruction of the linea alba. You know that the linea alba is the central tendon of the abdomen, which is very important. That's why people now are recommending approximation of the linea alba in all cases of ventral hernia. So you can do it with or without separation of the components, with preferably a reinforcement material like polypropylene. And these procedures are done with the maximum avoidance of surgical site infections. What is the burden of a ventral hernia? If you take the incidence of incisional hernia all over the world, it happens to almost 11 to 23% of the laparotomies. And this causes significant cause of morbidity to the patients, and also drainage of resources. In one study, they have shown that more than 50% of the resources are lost in developed countries for this surgery alone. The reported recurrence rate of more than 10% in most of the repairs is unacceptable. So if you examine the single important factor of this recurrence is the experience of the surgeon. So you all know the abdominal wall very well. That starts from skin, cambus fascia, scarpus fascia, adipose tissue, deep upper neurotic fascia, paired flat muscles, fascia transversalis, and peritoneum. I need not go about the details. But the nature is not so beautiful as we think. You can have hernias or abdomens like this. You can have hernias like this. We can have a colostomies maybe in the midline or in the lateral part like this. You can have scrotal hernias like this. So, because of these burdens, a global discussion is happening on to revisit the anatomy of anterior abdominal wall and assessment of the anterior abdominal wall, to formulate guidelines regarding the classification of hernia and the regulation on guidelines on how to go about in each type of hernia with the maximum reduction in the hernia recurrence rates with the prevention of surgical site infections. Actually, this is not a new phenomenon. The discussion about component separation started after this landmark publication from Ramirez et al. In 1990 in with a journal published in 1990 in Plastic Reconstructive Surgery Journal. This happened when there was a 40% recurrence background, and there was a background of 50% adverse events in case of incision hernia repairs. So you need to have a preoperative optimization of the patients, intraoperative technical innovations, and a good postoperative care. So regarding the preoperative assessment, usually globally this classification system is being used. Midline hernias and lateral hernias. Midline hernias are represented by M hernias, lateral hernias are represented by L hernias. And if the hernia is in the umbilicus, it is M3. If it is epigastric, it is M2. And if it is subsephious terminal, it is M1. And if it is just below the umbilicus, it is M4. And if it is suprapubic, it will be M5. Same way, if it is laterally, if it is subcostal, it will be L1. Flank, it will be L2. Iliac, it will be L3, and lumbar, it will be L4. Regarding the width, if it is less than 4 centimeter, it will be W1. If the width is between 4 centimeter and 10 centimeter, it will be W2. And if it is more than 10 centimeter, it will be W3. So you can define on whether it is M2, M3, W2, W2, or so you can classify accordingly. Suppose you have a hernia like this. This is classified as midline hernia. The height will be or length will be calculated from the upper margin from here and the lower margin from here. But you can have multiple hernias like this. In that case, the hernia calculation is done. The length is calculated from the upper margin of this defect and the lower margin of this defect This is the length of the whole hernia, and width also from the lateralmost part of the lateralmost hernia to this part is calculated as a width. So it is preferable to do CT imaging in all cases of complex hernia. So CT imaging is done to know about the loss of domain, especially to know about the muscle width, to know about the defect, to know about the adjacent pathology, the accompanying pathology, to know about the previous repairs in case of any fistulization of bowel that will be revealed. So a lot of information you will be getting in CT imaging. The increased abdominal wall thickness is associated with the increased success rate. The CT imaging, the width is measured midway between the linea alba and semilunar ligament at the umbilicus level. Loss of domain is nothing but a percentage of hernia volume in the total peritoneal volume. You will have to calculate the Tanaka Index. If it is more than, previously it was 25, if it is more than 20, it predicts difficulty with the closure. So you can calculate the Tanaka Index with this simple picture. This is the hernia and this is the abdominopelvic part. So you calculate the abdominopelvic volume by width, by depth, by length also, or by height also. Calculate the hernia volume by the same way. Together it is called the total peritoneal volume. And calculate the percentage of the hernia volume out of the total peritoneal volume. I will tell you a simple example. Suppose this is the CT scan. This is the widest diameter of the hernia. This is the depth and this is the length. So calculate the total hernia volume. 231 into 61 into 162, and we will have to, because it is not a box, lot of crevices and corners are there, so we will have to add a correction factor of 0.5 to make it ellipsoid. So the total hernia volume here is like this. And calculate the abdominopelvic volume the same way. Height, width and depth. And calculate the abdominopelvic volume. Here it is the abdominopelvic volume. Height into width into depth into correction factor. That is the total abdominopelvic volume. This is added together. That is the total peritoneal volume. So this is the figure here. So the loss of domain is hernia volume out of total peritoneal volume percentage. Here the Tanaka Index is 12%. That means hernia repair will not result in serious cardiorespiratory compromise. Probably this is another CT showing a loss of domain showing more than 20% of the hernia volume out of total peritoneal volume. Now coming to abdominal wall reconstruction. So there will be a separate sessions on CT reading and posterior component separation, anterior component separation. I will be going through the overall form of this thing, abdominal wall reconstruction. Now before going to that, we must know some terminologies. So you can see that you all are done open surgeries. Usually we do keep the mesh over the rectus muscle, over the rectus sheath. that terminology or keeping the mesh over the anterior rectus sheath, it is called onlay repair. If you are bridging the recti with a mesh, it is called interlay repair. If you are keeping the mesh just beneath the rectus muscle, it is called sublay repair. If you are keeping the mesh between the peritoneal membrane and the posterior rectus sheath, it will be underlay repair. And if you are keeping like IPOM inside the abdominal wall or beneath the peritoneal membrane, it will be called intraperitoneal. So it can be onlay repair, can be interlay repair, can be sublay repair, can be underlay repair, can be intraperitoneal repair. Now coming to sublay repair, actually that the whole idea of AWR is keeping the mesh in a very good position or good shape in a space where it will be tissue integrated. So a word about sublay repair, it was actually devised by three surgeons, Rives, Stoppa-Wantz. It is nothing but a retrorectus repair. That means that the mesh is kept beneath the muscle above the posterior rectus sheath. That has got a track record of almost 2 centuries, and it got the gold standard by the AHS in 2004, and it has got a recurrence of 10% or less. And if the midline hernia is less than 10 centimeter, it can be repaired, but if it is more than 10 centimeter, it cannot be repaired because you need to keep the mesh laterally. So it is not suitable for, because it's subfacial beneath the rectus muscle, it's not suitable for laterally placed hernias. It's not ideal for below arcade line repairs also. So this is the space you create for subfacial repair. This is the midline. You divide here, keeping the linea alba there, and keep a mesh here. That is sublay Rives Stoppa. So last day Dr. Rahul Mahadar was showing it up Rives Stoppa. Means you are coming extraperitonially, keeping the mesh in the sublay, this retrorectus area. But if the hernia is large or more than 10 centimeter, this mesh is not enough. You will have to overlap laterally. So you need to have a space which is not readily available, but you can make it laterally. So that is what is component separation. So you can have two types of component separation: anterior component separation and posterior component separation. The principle is, it is re-establishing a functional abdominal wall with autologous tissue repair with a midline closure. The midline closure, the central tendon of abdomen, is important. Now, this picture will show you how the midline is closed in anterior and posterior. Usually, the anterior and posterior component separation should not be combined together. Usually, the anterior component separation, you make a nick here or incision here lateral to the rectus muscle on the external oblique aponeurosis. This is the external oblique muscle. This is the internal oblique muscle. This is the transverse abdominis muscle. So external oblique aponeurosis if you make an incision laterally, this flap can be advanced medially if you separate this one laterally between the external oblique aponeurosis and the internal, which is an avascular place. But when the anterior component separation was first published by Rives et al., he combined this incision plus a cut in the posterior rectus sheath so that this can be more advanced. With a cut in the, it's not a separation, it's a cut in the posterior rectus sheath plus a cut here, external-oblique aponeurosis, so that you can advance. That was the one published by Rives et al. Now, that is the Rives et al. Fasciotomy on the external-oblique aponeurosis at the lateral edge of rectus muscle. You make a plane between the external oblique and internal oblique aponeurosis, and this allows 10 centimeter medial advancement of each if you are doing on both sides, each flap. So here you can see the midline is open here. This is the internal oblique and this is the transverse abdominis, this is the external oblique. A cut is made longitudinally lateral to the rectus muscle, that is anterior component separation. Actually, Rives made a cut here also, posterior rectus sheath middle also, to have a good advantage. See, this a plane is created between the external oblique external oblique muscle and the internal oblique muscle. But it is less successful in subcostal, subsequent or laterally placed hernias. Dr. Pramod Shinde will be throwing more lights on it next Sunday, 4 p.m. He will be coming live. In this Senadhipan Education Foundation, he will be throwing more lights on anterior components separation. So you will have to create a lipocutaneous flap. Sometimes the flap can go necrosed. The transaction of deep epigastric perforate is possible, but you can have surgery without transaction also. He will be describing it in detail. There can be midline wound adhesions and necrosis can be avoided by closed fasciotomy like incision. He will be describing it more. Now coming to posterior component separation. This allows placement of very large prostheses. This allows expansion of the abdominal cavity. This can treat hernias of the midline as well as hernias of the lateral side also. It is suitable for hernias near the bony margins because you are going to that deep to that bony margins, and the recurrence rate is less than 10%. For that, you need to revisit the anatomy again. Now, in the anatomy days, we learned about the external oblique aponeurosis, internal oblique aponeurosis, and transverse abdominis muscle. But we forgot to learn about an overlap of transverse abdominis muscle happening below the rectus, that is advancing below the rectus, which is very important in posterior component and separation. If you take a CT of abdomen, that is very evident that above the umbilicus, this transverse abdominis muscle is overlapping medially behind the rectus muscle. So that is important. I will be coming to it later. So you can see that the CT scan is there. This is the midline. This is the rectus muscle. This is the external oblique muscle. This is the internal oblique muscle. This is the transverse abdominis muscle. Here you can see that the transverse abdominis muscle is seen medially to this level, to the lateral aspect of rectus muscle. But if you come towards the umbilicus, you can see that slowly that is receding laterally. So this is important in component separation. So the same thing, this is the cross section above the arcuate line. This is the cross section below the arcuate line. You know that below the arcuate line, the posterior or the transverse abdominis muscle and its aponeurosis go anterior to the rectus muscle. Now coming to TAR, transverse abdominis release. So this is the essence of, we can see that this is the rectus muscle, this is the inferior epigastric artery and vein, probably from here the superior epigastric artery, and so lateral that gives branches, and that will be accompanied by the nerves from the spine. So these branches and the nerves go together. Where they go? Just medial to the semilunar line. If you take this cross section, you can see that this is superior epigastric artery, this is inferior epigastric artery, these are the branches going. Here it will be accompanied by the nerves coming from the spine laterally up to this area, and that pierces just medial to the level of semilunaris. So if you open just medial to the this neurovascular bundle, you will see the overlapped transverse abdominis muscles. And if you pick this transverse abdominis muscles with a right angle, you can divide that muscles medial to the semilunaris line, almost 1 to 2 centimeter medial to semilunaris line. You can go between this plane, transverse the posterior fascia and the transverse abdominis muscle. The same thing, you can see that the midline is there, posterior sheath is there, gone medially. Now we can take a right angle, pick the muscles, cut it, then you can go laterally like this. So that is what is posterior component separation. So after this component separation, you can see that you can go up to the flank near the gyrota fascia, lateral to the gyrota fascia here, lateral to the gyrota fascia here, and you can extend the subfacial repair laterally by keeping a largest mesh possible in the anterior abdominal wall. And also you can, because this posterior sheath is open, you can advance the flap and close the midline here. That is the crux of posterior component separation. This is one of my patients. You can see that the loss of domain is there. You can see that the abdominal hernia is falling near to the knees. Component separation is happening. You can see that the posterior component, you can see the layers here. The posterior component separation is already happened, and you can keep a mesh from this flank to the other flank. Finally, you can close the abdomen. So if it is not possible to do the advance, we can have myocutaneous flap, especially when the defects are more than 200 centimeters square. Of course, the surgical site occurrences like wound cellulitis, surgical site infection, seroma, recurring interventions, wound adhesions, hematoma, and enterocutaneous possible. All are possible here also, but it's minimal, especially when you are doing it by minimally invasive method. Now, we have heard about BOTOX injection. Actually, if you are assessing that the lateral muscles are not advanceable even after release posteriorly or even anteriorly, it's better to give a BOTOX injection to the muscles. BOTOX is nothing but botulinum toxin A. It is a neurotoxin produced by the Clostridium botulinum. It is inhibitory effect on presynaptic cholinergic nerve terminals. And functional denervation usually after the injection happens in 2 days time, and peak effect usually happens after 4 to 6 weeks. So the injection you will have to give the injection at least 2 weeks prior, and you will have to inject at least 200 to 300 units, 2 units per ml. You will have to inject diluted in normal saline, preferably ultrasound guided, mostly into external oblique and internal oblique muscles, and some inject into transverse abdominis muscles. You can have a advancement of flap for this. This is just a preliminary discussion about the abdominal wall reconstruction. We will be coming with the videos. We will be coming with all the procedures later. So I hope the beginners especially understood the principles of abdominal wall reconstruction. And finally, some people are unaware of the terms which is used in AWR. Though it is looking like a fancy words, it's nothing big about it. You all know about TEP and TAP. TEP is totally extraperitoneal placement of processes. So what is ETEP? ETEP is enhanced view TEP. Because in TEP, now at least they have agree that the vision is not adequate. In ETEP, if you are keeping the ports higher up, you will be getting an enhanced view. But in TEP, you keep the transverse fascia down. Here you bear the muscles. That is the only difference in the plane. ETEP Revistoppa, Dr. Mahadar was showing the ETEP Revistoppa. He will be taking a class on ETEP Revistoppa and his techniques. ETEP Revistoppa, actually, this is subfacial repair going beneath the rectus muscle, making a space between, taking down the posterior rectus sheath on both sides, crossing to the opposite side, closing the posterior rectus sheath, and then keeping a mesh. ETEP Revistoppa. Scola is nothing but subcutaneous onlay mesh by laparoscopic approach. Means you are keeping, as you are keeping in the open era, you are keeping in the over the rectus muscle. So the same way you can do it endoscopically also. That is scola. But that the problem with the scola is that will be having lot of seromas. ETEP TAR, I was telling about the TAR, means transverse abdominis release. The same you can do 2 ways. One is Laparoscopically, you can make an incision lateral to the border of the defect, take down the posterior rectus sheath, incise the transverse abdominis muscle, go laterally, and do the same thing on both sides, that is bilateral TAR. The same thing you can do with the ETUP also, means totally extraperitoneal also. The advantage is that you need to have only one-sided ports and you are not violating the peritoneum, but most of the time have it because it's a large hernia. Most of the time you will have to go to the peritoneal cavity. E-Melos is nothing but minimally invasive or less open subfacial repair. Minimally invasive or less open subfacial repair. ELAR is endoscopy assisted linea alba repair. Nothing big about it. Endoscopy assisted linea alba repair. TESLAR is totally endoscopy supraapponeurotic linea alba repair. Usually this E-Melos is done for the umbilical and epigastric hernia. So these are the terminologies commonly used in AWR. Nothing big about the terminologies. So we will be describing each and every technique in the later sessions. Thank you all for the patient listening.